Chronic obstructive pulmonary disease. Introduction. Emphysema and chronic bronchitis are the two most common conditions that contribute to COPD. These two conditions usually occur together and can vary in severity among individuals with COPD. Chronic bronchitis is inflammation of the lining of the bronchial tubes, which carry air to and from the air sacs, alveoli, of the lungs. It's characterized by daily cough and mucus, sputum, production. Emphysema is a condition in which the alveoli at the end of the smallest air passages, bronchioles, of the lungs are destroyed as a result of damaging exposure to cigarette smoke and other irritating gases and particulate matter. COPD. Definition. Chronic obstructive pulmonary disease, COPD, is a lung disease characterized by chronic obstruction of lung airflow that interferes with normal breathing and is not fully reversible. The more familiar terms, chronic bronchitis and emphysema, are no longer used, but are now included within the COPD diagnosis. COPD is disease characterized by airflow limitation that is not fully reversible. The airflow limitation is usually progressive and associated with an abnormal inflammatory response of the lung to noxious particles or gases, resulting in narrowing of airways, hypersecretions of mucus and change in the pulmonary vasculature. Chronic obstructive pulmonary disease, commonly referred to as COPD, is a group of progressive lung diseases. The most common are emphysema and chronic bronchitis. Chronic obstructive pulmonary disease, COPD, is a chronic inflammatory lung disease that causes obstructed airflow from the lungs. Symptoms include breathing difficulty, cough, mucus, sputum, production and wheezing. Causes. Smoking is the main cause of COPD. The more a person smokes, the more likely that person will develop COPD. But some people smoke for years and never get COPD. In rare cases, non-smokers who lack a protein called alpha-1 antitrypsin can develop emphysema. Other risk factors for COPD are exposure to certain gases or fumes in the workplace, exposure to heavy amounts of second-hand smoke and pollution, frequent use of a cooking fire without proper ventilation. Pathophysiology. Signs and symptoms. Signs and symptoms of COPD may include shortness of breath, especially during physical activities, wheezing, chest tightness, a chronic cough that may produce mucus, sputum, that may be clear, white, yellow or greenish, frequent respiratory infections, lack of energy, unintended weight loss, in later stages, swelling in ankles, feet or legs. People with COPD are also likely to experience episodes called exacerbations, during which their symptoms become worse than the usual day-to-day variation and persist for at least several days. Stages of COPD. Diagnostic evaluation. Diagnosis and assessment of COPD must be done carefully since the three main symptoms are common among chronic pulmonary disorders. Health history. The nurse should obtain a thorough health history from patients with known or potential COPD. Physical examination using stethoscope. Listen to the abnormal lung sound. Screening for alpha-1 antitrypsin deficiency. Screening can be performed for patients younger than 45 years old and for those with a strong family history of COPD. Chest X-ray may reveal hyperinflation of lungs, flattened diaphragm, increased retrosternal airspace, decreased vascular markings bullae, emphysema, increased bronchovascular markings, bronchitis, normal findings during periods of remission, asthma. Pulmonary function tests, done to determine cause of dyspnea, whether functional abnormality is obstructive or restrictive, to estimate degree of dysfunction and to evaluate effects of therapy, e.g., bronchodilators. Exercise pulmonary function studies may also be done to evaluate activity tolerance in those with known pulmonary impairment progression of disease. The forced expiratory volume over 1 second, FEV1 reduced FEV1 not only is the standard way of assessing the clinical course and degree of reversibility in response to therapy, but also is an important predictor of prognosis. Total lung capacity, TLC, functional residual capacity, FRC, and residual volume, RV may be increased, indicating air trapping. In obstructive lung disease, the RV will make up the greater portion of the TLC. Arterial blood gases, ABGs determines degree and severity of disease process, e.g., most often PaO2 is decreased, and PaCO2 is normal or increased in chronic bronchitis and emphysema, but is often decreased in asthma, pH normal or acidotic, mild respiratory alkalosis secondary to hyperventilation, moderate emphysema or asthma. DL-CO test assesses diffusion in lungs. Carbon monoxide is used to measure gas diffusion across the alveolar membrane. Because carbon monoxide combines with hemoglobin 200 times more easily than oxygen, it easily affects the alveoli and small airways where gas exchange occurs. Emphysema is the only obstructive disease that causes diffusion dysfunction. Bronchogram can show cylindrical dilation of bronchi on inspiration, bronchial collapse on forced expiration, emphysema, enlarged mucus ducts, bronchitis. Lung scan, perfusion ventilation studies may be done to differentiate between the various pulmonary diseases. COPD is characterized by a mismatch of perfusion and ventilation, i.e., areas of abnormal ventilation in area of perfusion defect. Complete blood count, CBC, and differential, increased hemoglobin, advanced emphysema, increased eosinophils, asthma. Blood chemistry, alpha-1 antitrypsin is measured to verify deficiency and diagnosis of primary emphysema. Sputum culture determines presence of infection, identifies pathogen. Cytologic examination rules out underlying malignancy or allergic disorder. Electrocardiogram, ECG right axis deviation, peaked P waves, severe asthma, atrial dysrhythmias, bronchitis, toll, peaked P waves in leads 2, 3, AVF, bronchitis, emphysema, vertical QRS axis, emphysema. Exercise ECG, stress test, helps in assessing degree of pulmonary dysfunction, evaluating effectiveness of bronchodilator therapy, planning evaluating exercise program. Medical management. There are many types of medications and treatments available to make life with COPD easier. These include both inhaled and oral, taken by mouth, medications. Bronchodilators to relieve shortness of breath. Combination bronchodilators and anti-inflammatories to relieve shortness of breath and to prevent flare-ups. Antibiotics to fight infections. Supplemental oxygen tank, to help with low oxygen and energy levels. Vaccines for flu and pneumonia to help prevent infections. Inhalers. The main medication treatment for COPD comes in inhalers. Sometimes, these are called puffers. There are many types of inhalers and devices. Bronchodilator inhalers. Bronchodilators open up the airways in the lungs, making it easier to breathe. There are two main groups of bronchodilators. Beta-2 agonists. Anticholinergics. Beta-2 agonists relieve breathlessness. They can be taken for prevention or providing a quick relief. They are inhaled medicines that can be short-acting or long-acting. Short-acting beta-2 agonists are often used as a rescue or quick relief medicine to open airways quickly. Long-acting beta-2 agonists may also be taken regularly to prevent breathlessness. Anticholinergics relieve breathlessness, but in a different way than beta-2 agonists. They are also inhaled medicines that are effective in treating COPD, especially when they are taken on a regular basis. There are short-acting and long-acting anticholinergics. Nebulizer medication. Nebulizer is a device that turns medication into fine mist and delivers it into your airways, using a mouthpiece or a mask. Nebulizers can be used for those patients who have a difficult time using inhalers. Oral medications. Corticosteroid pills. Corticosteroids also come as pills, most often known as prednisone. Corticosteroid pills have more side effects than the inhaled corticosteroids that are in combination medicines. Corticosteroid pills are often used for short periods of time, usually when patient has a COPD flare-up. Antibiotics. Bacterial infections in the airways may cause some of your COPD flare-ups. Antibiotics can help in these cases. However, antibiotics will not work if your flare-up was caused by a viral infection. Sometimes people may be experiencing both bacterial and viral infections at the same time. Prednisone is often prescribed along with antibiotics. Phosphodiesterase 4 inhibitors. Phosphodiesterase 4 inhibitors, PDE4, medications are a type of oral medication that decreases inflammation in the lungs. This pill is used for patients with a history of frequent flare-ups and chronic cough with mucus, phlegm. It can prevent flare-ups and should be used along with regular inhalers. Mucolytics. Mucolytics help to remove secretions, unwanted contents like phlegm, from the lung by thinning mucus so it is easier to cough up. These medications are for patients with frequent flare-ups. Mucomyst. N-acetylcysteine NAC, may prevent flare-ups. Vaccines. COPD increases risk of other respiratory problems. For that reason, doctor might recommend to get a yearly flu shot, the pneumococcal vaccine, or the whooping cough vaccine. Surgical management. There are two types of lung surgery performed to address COPD. Bulectomy is a procedure where doctors remove one or more of the very large bullae or blebs from the lungs. Bullae are large air sacs that form from hundreds of destroyed alveoli. These air spaces can become so large that they crowd out the better functioning lung and interfere with breathing. For those people, removing the destroyed air sacs improves breathing. Lung volume reduction surgery, LVRS, is a procedure to help people with severe emphysema affecting the upper lung lobes. LVRS is not a cure for COPD but can improve one's exercise capacity and quality of life. The goal of the surgery is to reduce the size of the lungs by removing about 30% of the most diseased lung tissues so that the remaining healthier portion can perform better. LVRS also can allow the diaphragm to return to its normal shape, helping you breathe more efficiently. The surgery has been shown to help improve breathing ability, lung capacity and overall quality of life among those who qualify for it. Lung transplants. Sometimes COPD can cause severe damage to the lungs, causing them not to function normally. Doctor may recommend a lung transplant if the damage is not repairable. Lung transplants can improve ability to breathe and be active. However, like any major operation, patient should consider the risks and complications, such as organ rejection or needing to take immune-suppressing medications daily. Nursing management. Nursing assessment. Assessment of the respiratory system should be done rapidly yet accurately. Assess patient's exposure to risk factors. Assess the patient's past and present medical history. Assess the signs and symptoms of COPD and their severity. Assess the patient's knowledge of the disease. Assess the patient's vital signs. Assess breath sounds and pattern. Diagnosis. Diagnosis of COPD would mainly depend on the assessment data gathered by the healthcare team members. Impaired gas exchange due to chronic inhalation of toxins. Ineffective airway clearance related to bronchoconstriction, increased mucus production, ineffective cough, and other complications. Ineffective breathing pattern related to shortness of breath, mucus, bronchoconstriction, and airway irritants. Self-care deficit related to fatigue. Activity intolerance related to hypoxemia and ineffective breathing patterns. Planning and goals. Goals to achieve in patients with COPD include improvement in gas exchange, achievement of airway clearance, improvement in breathing pattern, independence in self-care activities, improvement in activity intolerance, ventilation oxygenation adequate to meet self-care needs, nutritional intake meeting caloric needs, infection treated prevented, disease process prognosis and therapeutic regimen understood, plan in place to meet needs after discharge, nursing priorities, maintain airway patency, assist with measures to facilitate gas exchange, enhance nutritional intake, prevent complications, slow progression of condition, provide information about disease process prognosis and treatment regimen, nursing interventions, Patient and family teaching is an important nursing intervention to enhance self-management in patients with any chronic pulmonary disorder. To achieve airway clearance, the nurse must appropriately administer bronchodilators and corticosteroids and become alert for potential side effects. Direct or controlled coughing. The nurse instructs the patient in direct or controlled coughing, which is more effective and reduces fatigue associated with undirected forceful coughing. To improve breathing pattern. Inspiratory muscle training. This may help improve the breathing pattern. Diaphragmatic breathing. Diaphragmatic breathing reduces respiratory rate, increases alveolar ventilation, and sometimes helps expel as much air as possible during expiration. Pursed lip breathing. Pursed lip breathing helps slow expiration, prevents collapse of small airways, and control the rate and depth of respiration. To improve activity intolerance. Manage daily activities. Daily activities must be paced throughout the day, and support devices can be also used to decrease energy expenditure. Exercise training. Exercise training can help strengthen muscles of the upper and lower extremities and improve exercise tolerance and endurance. Walking aids. Use of walking aids may be recommended to improve activity levels and ambulation. To monitor and manage potential complications. Monitor cognitive changes. The nurse should monitor for cognitive changes such as personality and behavior changes and memory impairment. Monitor pulse oximetry values. Pulse oximetry values are used to assess the patient's need for oxygen and administer supplemental oxygen as prescribed. Prevent infection. The nurse should encourage the patient to be immunized against influenza and S. pneumonia because the patient is prone to respiratory infection. Evaluation. During evaluation, the effectiveness of the care plan would be measured if goals were achieved in the end, and the patient identifies the hazards of cigarette smoking, identifies resources for smoking cessation, enrolls in smoking cessation program, minimizes or eliminates exposures, verbalizes the need for fluids, is free of infection, practices breathing techniques, performs activities with less shortness of breath. Prevention. Prevention of COPD is never impossible. Discipline and consistency are the keys to achieving freedom from chronic pulmonary diseases. Smoking cessation. This is the single most cost-effective intervention to reduce the risk of developing COPD and to stop its progression. Healthcare providers should promote cessation by explaining the risks of smoking and personalizing the at-risk message to the patient. Complications. There are two major life-threatening complications of COPD: respiratory insufficiency and failure. Respiratory failure. The acuity and the onset of respiratory failure depend on baseline pulmonary function, pulse oximetry or arterial blood gas values, comorbid conditions, and the severity of other complications of COPD. Respiratory insufficiency. This can be acute or chronic, and may necessitate ventilator support until other acute complications can be treated.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.